Her life.
Thank you. So, hello everyone. Welcome at our technical session entitled Artificial Intelligence in Healthcare, Bridging Gaps and Understanding Diversity. I am Dr. Wala Mahmoud. I am a physician and a researcher at National Research Center, a biological anthropology department, Institute of Medical Health and Clinical Study in RC, Egypt. I would like to welcome all my colleagues as panelists here. Dr. Laura Stella, Dr. Natalie, Dr. Christian, and we are waiting Dr. Nicole, if I didn't miss anyone. I will start because we have time limited for our session. So I will introduce Dr. Laura, if I pronounce your name exactly right. When we ready, you can share your screen. Dr. Laura Stella Gnoma is a lecturer and OWSD National Chapter Congo Republic. She is a biologist with a passion for research methods, and she began her research as a student in CAN-TAM 1 project since 2009 until 2013. And this project was focused on assessing the situation of Mycobacterium tuberculosis infection in Pasig Valley, and setting up a cohort for future interventions against this disease. And then she was supervisor of the project CANDAM 2 from 2017 and until 2020. Which focused on assessing the situation also of Mycobacterium tuberculosis, a very important infection in Africa, at the Makaliki Base Hospital. And this project was the first EDCTB supported regional network for excellence in sub-Saharan countries, Africa. I would like I see her biography is very rich. She is one of Organization for Women in Science for Developing World. And also she has African Research Network on neglected topics. Thank you so much for this rich bio. You can share your screen now, if you please, and there's a floor for you. You are hearing me, Dr. Laura?
Yeah.
Yes. So please, you can start your presentation now.
Okay. Thank you. But I present in French. My presentation is in English, but my pronunciation is not good. But I present in French. It's correct? Okay.
Yes.
Okay. Partage oui, je vais partager fichier. Voilà. Je vais aller partager. Comment je vais partager mon histoire? Partager. Écran. Voilà, c'est bureau. Okay. Ok, bonjour tout le monde. Je ne sais pas si on m'entend. Bonjour tout le monde.
No, still not presenting your PowerPoint.
Ok, bonjour, donc je me présente. Je m'appelle Laure Stella Gomalissi, je suis biologiste. et épidémiologiste. J'ai une expertise aussi en système d'information sanitaire.
Dr. Laura, excuse me, I can't see your PowerPoint play as a presentation. I see your desktop.
Oh là là. You can see my presentation. Qu'est-ce que c'est quoi ça?
I think yes, I didn't see. Anyone sees a PowerPoint play?
No, we don't see any.
Non. Oh là 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 là.
I think no.
Comment je peux partager l'écran? Oh là 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 là.
You can send your PowerPoint by email or
Yes, oh. Okay.
yes. Yes, I
You
see.
see?
Yes, I think you can start now.
Okay.
Yes, thank you so much.
Okay, thank you very much. Donc, I present myself. Goma Lingisi-Lorstila, doctor in biology, molecular biology, and epidemiologist. I continue in French.
Yes,
Donc,
okay.
je suis docteur Goma Lingisi-Lorstila. J'ai un doctorat en biologie moléculaire, chercheur à l'Institut national de recherche en sciences de la santé, et j'ai une expertise dans le domaine du système d'information sanitaire et en épidémiologie. Il m'a été demandé donc de vous présenter une présentation qui porte sur vers une santé inclusive, investir dans les soins de santé primaire en République du Congo, et tout en mettant l'accent sur les infections. En ce qui concerne donc la présentation, en ce qui concerne donc l'introduction, la présentation, nous discuterons sur l'importance d'investir dans les soins de santé primaire et justement en mettant l'accent sur les infections. Les soins de santé primaire sont le premier point de contact de la population avec le système de santé. Et d'une manière globale, donc dans le contexte global, l'accès à des soins de santé de qualité reste un défi majeur pour de nombreuses populations et même pour la population congolaise. Les soins de santé primaire jouent un rôle crucial dans la promotion de la santé, dans la prévention et dans la gestion des infections.
La plupart we see your slides are not moving.
Yes, I'm starting. Donc, la plupart des pays qui investissent dans les systèmes de soins de santé primaire constatent des améliorations significatives en termes de santé de la population, de réduction des inégalités et de maîtrise des coûts de santé à long terme. Et donc, concernant l'introduction, nous sommes basés sur 3 points. D'abord, la vision de la République du Congo concernant donc les soins de santé primaire, les problèmes des infections en République du Congo, et puis l'explication même du concept de soins de santé primaire. Donc, concernant la vision pour la République du Congo, donc le Congo s'est engagé à améliorer l'accessibilité et la qualité des soins pour tous les citoyens. Sa vision consiste donc à mettre en place un système de soins de santé primaire inclusif et efficace qui garantit une couverture sanitaire universelle et qui répond aussi aux besoins spécifiques de la population. En résumé, le Congo s'aligne dans l'objectif de développement durable numéro 3 qui parle donc d'une bonne santé et d'un bien-être. Concernant le problème des infections en République du Congo, le Congo est confronté à un problème persistant donc, des infections qui affectent la santé de la population. Et ces infections continuent de représenter une charge importante pour le système de santé. Et quelles sont ces infections qui sont de plus en plus, qui demeurent de plus en plus dans notre population? On trouve le paludisme, la tuberculose, le VIH-Sida, les infections respiratoires aiguës, les infections urinaires, les infections sexuellement transmissibles. Et les facteurs contributifs comprennent, donc parmi les facteurs contributifs qui favorisent ces infections, il y a la précarité des conditions de vie, il y a le manque d'infrastructures sanitaires adéquates, il y a l'accessibilité aux services de santé, mais il y a aussi les défis qui sont liés à la sensibilisation et à l'éducation en matière de santé. Alors, quelle est l'explication que nous donnons au concept de soins de santé primaire? Cela désigne des services de santé essentiels qui sont universellement accessibles, abordables et offerts aux individus et aux communautés en tant que premier point de contact avec le système de santé. Il s'agit donc d'une approche globale axée sur la promotion de la santé, sur la prévention des infections et des maladies et sur la fourniture des soins initiaux pour les infections courantes et pour les affections chroniques. Les soins de santé primaire sont dispensés par une équipe de professionnels qui englobe donc les infirmiers, les assistants sanitaires, les laborantins. En ce qui concerne l'importance de soins de santé primaire, nous avons abordé ce thème en 2 points. D'abord, l'infection, la prévention des infections et la gestion des infections. Concernant la prévention des infections, il y a tout d'abord l'éducation sanitaire et la promotion de l'hygiène. Au Congo, la sensibilisation du public aux pratiques d'hygiène et à la nutrition et à la prévention des infections se fait au niveau des centres de santé primaires. Il y a aussi la vaccination, donc les vaccinations ou bien l'immunisation qui se fait dans les centres de santé primaires. Et cela consiste donc à administrer des vaccins pour prévenir les infections et renforcer l'immunité. L'exemple qui me vient en tête, c'est par exemple les vaccins qui sont donnés à l'enfance. Le BCG, les vaccins contre la polio qui sont donnés à l'enfance, et il y a aussi des vaccins qui sont donnés aux femmes enceintes. Par exemple, le vaccin contre le tétanos.
Dr. Laura, excuse me. I received many requests to present your presentation by English language. I know you are not fluent or something like that, but it's okay, no problem. You can try because your presentation is very interesting and many interested to hear you in English language. Would you please obey this request?
I can try in English. You want to speak in English?
Yeah, but because the translation on Facebook didn't translate accurate for your speak in French. So if you can speak in English, it will be appreciated. Thank you.
Importance of primary healthcare. Primary healthcare refers to the essential healthcare service that are universally accessible, available, and provided to individual and community as their first point of contact with the healthcare system. It's a comprehensive approach to focus on promoting health, preventing disease, and providing initial care from common illness and chronic conditions. And primary health care encompasses a wide range of services, including disease prevention, health promotion, diagnosis, treatment, and management of health conditions. It's delivered by a team of healthcare professionals, such as practitioners, nurses, midwives, and community health workers who work together to meet the diverse healthcare needs of individuals and population. And the key role of primary healthcare in the prevention, early detection, and management of infection. Primary healthcare Primary health care plays a crucial role of addressing infection by focusing on prevention, early detection, and effective management. Concerning prevention, primary health care emphasizing preventive measures such as immunization, health education, and promoting healthy behaviors. And early detection, primary health care is often the first point of care for individuals seeking health care. Through regular checkups, screening, and diagnostic tests, primary health care provider can detect infection at the early stage. And early detection allows for timely intervention, treatment, and management, reducing the risk of complication and further transmission. Management and treatment. Primary health care provides and are trained to manage and treat common infection effectively. They can prescribe appropriate medication, provide necessary treatment, and offer guidance on self-care and disease management. By offering comprehensive care, primary health care helps individuals recover from infection and prevent the development of more severe health conditions. Concerning benefit and screening primary health care to combat infection. Screening primary health care system can yield several benefits in combating infection. Improve access. A strong primary health care system ensures equitable access to healthcare system, including prevention, early detection, and treatment of infection. This is particularly vital in understanding aware or marginalized population where access to healthcare may be limited. Cost effectiveness. Primary health care focuses on preventing measures and early intervention, which can lead to cost saving by reducing the need for expensive hospitalization and expensive treatment. By addressing infection at an early stage, early healthcare can help contain the overall healthcare costs. Concerning integrating and coordinate care, primary healthcare provides a platform for coordination and integrating care, ensuring that individuals receive comprehensive service throughout their healthcare journey. Infectious diseases are a lead cause of illness and death in the Republic of Congo. These diseases are often preventable and treatable, but access to quality healthcare is limited for many people. Children, pregnant women, and people living in poverty are especially vulnerable to infectious disease. And infectious diseases are a lead cause of illness or death in our country. This disease can be caused by bacteria, virus, parasite, and fungi. They can spread through contact with contaminated water, food, or soil, or food contact with infected people or animals.
And you have 1 minute. You have 1 minute, okay?
Okay. And primary health care is a first point of care for most people with health care. And primary health care can play a vital role in addressing infectious disease by providing preventing care, diagnosing and treating infectious early, and referring patients to specialists for more complex care. There are a number of factors that contribute to the burden of infectious disease in the Republic of Congo. This challenge makes it difficult for people to prevent and treat infection. For example, lack of access to clean water and sanitation can lead to the spread of waterborne diseases, such as diarrhea. And poverty can make it difficult for people to afford health care or to purchase essential medicines. Malnutrition can break the immune system and make people more susceptible to infect. The presentation of the main type of prevalent infection in the country. The country has several prevalent types of infection, include respiratory disease, respiratory infection such as upper respiratory tract infection and lower respiratory tract infection are common. They can be caused by virus, bacteria, or other pathogens. Gastrointestinal infection, including infectious diarrhea, are common. They are often caused by bacteria, virus, or parasites, and can spread through the consumption of contaminated water or food. Example of good practice and successful initiative in primary health care in other countries, as well as potential adaptation of this practice to the context of Republic of Congo. Integrating care model. Some countries have adopted.
Yes, thank you so much.
I can finish, please?
Yes, because we are running out of time.
Thank you. Integrating care model. Some countries have adopted integrating care model where different healthcare professionals work together to provide comprehensive care to patients. This can include primary care teams composed of doctors, nurses, pharmacists, and other healthcare professionals. The Republic of Congo could consider a strengthening coordination amongst different healthcare stakeholders to improve the delivery of primary healthcare. Utilization of community healthcare. Community healthcare are trained to provide basic healthcare in remote and underserved communities. And training and deploying community healthcare in the Republic of Congo could enhance access to primary healthcare in underserved regions. Concerning expanding the vaccination program, some countries are implementing expanded vaccination program to ensure high vaccination coverage against preventable disease. This program particularly targets children and at-risk population. And in the Republic of Congo, we could strengthen its vaccination program by expanding the range of available vaccine and improving access to vaccination throughout the country. And concerning health information and communication,
because we are running out of time, so we can move to our next presentation and they leave the time for question and answer for you. Thank you so much for your interesting presentation, Dr. Laura. So the next presentation about artificial intelligence and medical anthropology.
I'd like to introduce Dr. Wala Saad Mahmood. Dr. Mahmood is a researcher and in the Department of Biological Anthropology Department, Medical Research Division at the National Research Center. She's also an associate professor at the Missouri University of Science and Technology in Egypt. Her doctoral studies is in child and adolescent health and nutrition at the El Shams University. Dr. Mahmood holds a fellowship from the Japan Society of Promotion of Science, as well as the Indian Council of Medical Research. Dr. Mahmood is a member of the JSPS Alumni Association of Egypt. She's also a member of the Organization for Women in Science for the Developing World, UNESCO.
Thank you so much. My presentation today about the capacity of artificial intelligence to handle and evaluate massive data sets is one of its most important contributions to medical anthropology. Next, please. So let's throw a small introduction about what is the anthropology and what is the medical anthropology. Next. Yes, what is the anthropology? No, next, please. I don't know many of you hear about anthropology or not, and what is related of anthropology to medicine. So anthropology is, next slides, is defined as the study of what make us human. Anthropology, it's a Greek word from two parts. Anthropos is human and logos is study or science. So to understand the full sweep and the complexity of our culture across all human history, anthropology can draw and build upon knowledge from social and biological science, as well as humanity and physical science. So the anthropology has 4 or 5 main fields, subfields. We hear about archaeology, evolutions, ecology, and biological anthropology and cultural anthropology. And recently, not recently, but the applied anthropology is the 5th subfield. So archaeology is study of past human societies, human societies past from our now present. From their remains, from their historic artifacts, from structure of landscape, so we can study the human past. Ecology also study human behaviors and natural selection through theoretical models. Biological anthropology is my department in National Research Center. It's the study of human biology, including modern human and human evolution, human genetics, and inheritance. And we can see the medical anthropology subfield of biological anthropology. Actually, it combines biological anthropology and cultural anthropology. Last but not least is the study of cultural diversity, about demography, linguistic studies. It will be cultural anthropology. Next is the broad subfield, and every subfield, what's the study under these fields: biological anthropology, physical anthropology, forensic anthropology, human anatomy, human taxonomy. We can see many of sub-branches of biological anthropology to the left side, archaeology also, cultural anthropology and ethnology, linguistic anthropology, and applied anthropology, which can combine the cultural and the biological and forensic into applied anthropology. Is a quick introduction about what is anthropology. So artificial intelligence and anthropology. Sorry for in M. So artificial intelligence is recently introduced to our globe, and I believe that, and not only is my opinion, will impact all our life, not in science, but in our social life, in cultural life also. And the artificial intelligence would profoundly impact all branches of anthropology, including the applied anthropology. For example, in archaeology, we can see now at many of museums all over the world and also in Egypt as a virtual reality and the metaverse can access any museum by this artificial intelligence, and also you can enhance artifact analysis, reconstructed ancient environment, and can identification of undiscovered sites, like in what is discovered in Great Pyramids in Egypt, in Giza. On the other hand, in biological anthropology, we can biological anthropology can benefit isolated complex of genetic data analysis. What's in the project in 2016, the human genome. And now in Egypt also it's a human genome, Egyptian genome project. In linguistic anthropology, we can teach and studying the endangered language by artificial intelligence, like mini app can translate this. So artificial intelligence will be very important for biological anthropology development and enhancement in future. So next, please. Our present lecture now is about medical anthropology, subfield of biological anthropology, like I mentioned before, and it will be a combination between culture and biological. So what is a medical anthropology? Medical anthropology and how to differ about the regular medicine. Medical anthropology, it's a field of anthropology focused on relationship between health and illness and culture. What make us get ill and sick, and what make us can describe this, our illness, and how can behave with this illness. So beliefs and practice in every community may be vary across different culture, and there is a lot of diversity all over the world, enhanced by social, religious, political, historical, and economic factors. Medical anthropology as subdivision or subdiscipline of anthropology process has been used to alleviate public health problem in many society. And this push WHO to applying medical anthropology and applied anthropology to public health branch in 2017. Because there was a large scale of outbreaks like Ebola virus diseases in Kenya and Liberia and Sri Lanka from 2013-2016, then Zika virus in North Central and South America, Southeast Asia in 2015, cholera in Yemen, polio vaccine injection in some areas. What is make all these disease and infection hit some countries and not any places else? Until COVID-19 hit a pandemic in all the globe, and medical anthropology will positioning support a big tent research agenda on health and society. So next, please. Here we can go to artificial intelligence. I wanted to mention that artificial intelligence, why it's artificial? Because human who makes this intelligence. Artificial intelligence all through the time we try to be like human, try to minimize human effect. Artificial intelligence application in healthcare, is many in healthcare and also in medical anthropology as it's part of healthcare and medicine. Very important in patient care, very important in medical imaging and diagnostic tools, very important in research and development, and as a physician for many tools now, as surgical robot, personalized medication and care. Now any patient can enter the hospital, can by his name, by family history, by genetic informations, can put a specific personalized medication for his disease. All this is very important for clinical trial and alternative diagnostic prescriptions. Now another part of our presentation is big data. What is a big data term, and what is the importance of big data in healthcare? So the definition of big data informally used in healthcare to describe data so bigger than few thousand points. It's not about sample size cutoff, but it's about how to interpretation of this big data in modern age. For storage, processing, and how it can bring this data into science and descriptive manner. So in medical anthropology, big data set may have many rows comprising the records of millions of patients, many columns corresponding to multiple features of each patient. We can put thousand of recorded data about every patient all through his life cycle, and then the next generation so can predict the disease and intervention. Next, please. So now we know that the biological and the hospital laboratory specimen in hospital biological samples, we have electronic records for health care. We have biometric some functions like pulmonary function, exercise tolerance, neural activity. All this data can collecting to refine the big data in medicine and can used by artificial intelligence to describe the health and disease through culture and through specific community. So when I train, when we training and artificial intelligence AI model for such a large scale data required intensive computing resources. So it's very important as developing countries and infrastructure, not such computer resources, but it's about infrastructure, strong internet, 5G networking. So it's extend beyond utilizing local on-premise supercomputing, but the ability to house and analyze data on large scale enable this to train powerful artificial intelligence model. As I mentioned before, artificial intelligence all through the time of this journey try to minimize or try to act like a brain of human. So we are training this artificial intelligence model to can interpret this big data. Once the AI model is trained, then we can processing using the model to generate prediction, what is called inference. And the inference is present in all sides of our lives, like smartphone voice, artificial assistant, like recommended comment in image search, spam filtering in our email, also in many product of applications. So big data, as I mentioned, as I would define it as massive amount of information collected through digitalizing of everything. So the era now is digitalization of every record for patient or for culture and society to can interpret this digitalized information and can analytic it. We can analyze by 3 steps or 3 phases: descriptive analysis, predictive analysis, and then prescriptive analysis. We can see this chart, its complexity and value. Descriptive analysis, what has happened. Like I mentioned before, descriptive analysis can describe the archaeology, anthropology, what has happened in the past of human culture. And then we can, after present this data and analytic data, we can predict what will happen. Me project in national research centers and in Ministry of Tourism about the ancient Egyptian population, what has happened to them in past history, and what will happen by genome and genetic studying. And then we can prescribe or prescriptive, doing a prescriptive analysis, how to make it happen, how they can make it happen or prevent it, foresight after insight situations. Next, please. I will go through rapidly about what is the descriptive analysis and what is how descriptive analysis, predictive and predictive analysis can do. I will not take time in this analysis. Next. So descriptive analysis, as I mentioned, it will all about what has happened. just the first step in making use our data. If you have example, many patients were admitted to the hospital last year as victim of motor vehicle accident. So how many is just about collecting data about how many fatality occurred in the accident, how many of them suffered infection, and so on. This is an elementary form of reporting. For example, we have some patient of diabetes every year, and how many of living with these diseases, with what are the benchmark outcome, or the prospect or other aspect of diabetic care, and so on. This is descriptive analysis. What is a predictive analysis? And as I mentioned, what we can predict what will happen. Next. What will happen? It's about predictions likely to happen. If you can imagine with me, you can predict what will happen in the future for patient. It will be a great impact for physician to predict the course of the prognosis of disease. Some sort like disease, cancer, for example. I am a BI of breast cancer project in National Research Center in combination with Bahia Hospital. So if we can predict what will happen for the patient in the next year, it will be great hope for every patient with cancer. For example, artificial intelligence by predictive analysis can help this. Several concepts need to work to ensure precise prediction. So artificial intelligence with machine learning and statistics can do this role. Next. Is another example from Singapore population electronic health record. We have clinician input, and we have a new patient by his lab report, by his clinical lab or diagnosis report. We can introduce all this deep analytic based prediction model for readmission, for example, and then we can predict the health complication hospital readmission index. Next.
Dr. Wala, can we wrap up in the next 2 minutes, please?
Yes, I will finish in 1 minute. Next, please. Next, Dr. Yes. Okay, I will move some slides. Next. Yes, next is always about predictive analysis. Next. So this is a slide I like, and I want to express is my dream to can report and can predict or monitoring all patients from away from getting a hospital or from go to emergency room by artificial intelligence, getting wearable smart watch, wearable something like implant in under skin. We can monitor a location of the patient. We can know the emergency situation for him, and so can take a very quick action. Next. As some sort of wearing devices, and artificial intelligence will help us through many ways. We can have electronic shoes, electronic socks, subcutaneous sensors, even tattoos in the skin, artificial displays, and all this can be body area networking for the network, so we can access any situation occurred to the patient. Next, please. I will skip some. Yes, next. Okay, no. One slide. Okay, so this slide this is one slide before the last summary. So artificial intelligence can play a very important role for patient, for radiologist, for physician, for researcher, for laboratory, and for drug maker. By many way, is this complete circle very important to organize itself. For a patient, we can make diagnosis. For laboratory and for drug maker, we can create and discover new drugs by this artificial intelligence and machine learning, deep learning also. And for researcher, we can collect all this for researcher, especially in biological anthropology and medical anthropology, to predict the disease in the future in specific culture. Next. So this is last slides. So take home message and my summary. artificial intelligence helps in drawing the pattern in all data that's coming in, not only the health data. Any data will enter to artificial intelligence can make drawing pattern to it. Apart from aiding in more efficient operation and insight into patient, her or his style, lifestyle, and health, AI can help in leveraging and analytic for making strategic decisions. It's very important to make a right decision for right person and right time. Human, machine, and what's in between. Thank you. So thank you so much, and thank you for your listening. Yes, thank you.
Oh, thank you for that interesting presentation. We're going to have Dr. Christian O'Lear, if you can introduce yourself. If we could just keep to the 12 minutes. I think we've got 3 more presenters that we have to do before we finish the session. Thank you.
I share my screen.
Yes, please.
It's okay. Perfect. You can see.
Yes, please go.
Okay. I'm start or I wait?
No, please start.
Okay. Good afternoon. Here is morning. So I am Cristian Castillo. I present my research is review in my practice and the practice of the clinical research, because here the title is Healthcare Analytics Evolution Data Mexico. In new dates and generation, the analytics is completely different before to 5 years ago, after to the COVID. In this moment, the hospital, public and private, analyze the other techniques. For example, for machine learning and AI. This decision is because it's better use the data for different decisions in the patient, for the doctors, and especially for the institutions. So the healthcare industry in Mexico involved, there was growing realization that non-descriptive analytics. This is the benefit for Mexico because have more fast the results and benefits for patients. So this is a new practice, but it's only a small hospital to implement it. The problem is don't have experts in IA, and it's more frequently they use the data in the statistic data. So this is a big problem here. And don't have a standard for training the data in the hospital, public in the north, on the south, on the middle. This is really the big problem, but the institutions maybe use these techniques in machine learning for better results, but it's complicated implementing. The data analytics is healthcare has become increasing. I told you the other slide. because it's important to improve patient care, operational efficiency, and profit value. In Mexico, the journal typically starts with descriptive analytics, where historical data used to understand past training and patterns in healthcare delivery. This may involve analyzing patient demography, treatments, outcomes, and results utilizations. Okay. Healthcare organization in Mexico use the data that could move towards predictive analytics. This involves using statistical algorithms and machine learning techniques to forecast future events or trends, such as predict patient administration rates or diagnosis disease early. This practice is used specific with COVID. And in this moment, the people use for older people, because here in Mexico, I have a comorbidity, diabetes, hypertension, and obesity. So this is the reason to use this static or use algorithm in machine learning. The ultimate goal of many healthcare providers in Mexico is to leverage advanced machine learning. But this is only, I don't remember exactly what second. It's only, okay, 10% of the institution public and 17% in private. So the percent use these algorithms, it's slow. For example, machine learning models can help personalize treatment plans based on individual patient characteristics. This is a different perspective, for the institutions. In general, the journey from descriptive to prescriptive analytics in healthcare in Mexico is a complex and involving different processes, but one that has the position to improve the patient care, reduce the cost, reduce the transport for the patients. Finally, when you use the IA for different case, you have more benefits. So this is one example. I think this the first healthcare systems is the Christus Munguerza, is private. This is the first hospital in Mexico and one of the first in Latin America to implement technology of a digital platforms that combine machine learning and artificial intelligence. So this is used when the people is hospitals. In Christus Muguerza have different institutions in Mexico, so facilitate training and learning in surgical techniques. So this is the most important right now in Mexico and Latin America healthcare system. And that's it. And my presentation is very quick because it's the research is developed in Mexico. So I have new data, but I can explain this moment because I analyze all data.
Thank you so much. Actually, you're in time. And no, it's okay. Your lecture is very fine. Thank you so much.
Thank you.
Thank you. So our next speaker, Dr. Natalie, you are ready? So let me introduce you. Our last speaker, Dr. Natali. She is senior lecturer of oral hygienist, University of Western Cape, South Africa. Your biography is very interesting because I like that you are liking to work about oral hygiene. To work in Department of Oral Hygiene, interest in health and oral promotion, clinical practice, and research. She have a particular interest in service learning in a community context, curriculum and community development. There are also area of many research and services that she engaged in. Currently, she looking forward to completing her PhD with our best wishes for completing your PhD in topic that presenting today. So please start your presentation about primary oral health care within substructure in the Cape Metro Health District, South Africa. Floor for you.
Thank you very much for that nice introduction and greetings from sunny Cape Town. As you've said, I'm talking about primary oral care. For some reason, my slide isn't moving. Oh, there we go. To start off, I want to raise the issue of the importance of oral health. We know that oral diseases are a major public health concern, and globally, untreated decaying permanent teeth is the most prevalent disease in adults of all diseases. And gum disease is the 6th most common disease, again, of all diseases. It's evident that from the time the first tooth has erupted, that tooth is exposed to being decayed, and you have increased morbidity and mortality of the dentition, and effect on the impact of quality of life increases with age. We know that oral problems are largely preventable, yet the prevalence is increasing, particularly in poor communities, and the consequences thereof are worsening, particularly amongst the poor and socially disadvantaged. In South Africa, dental caries and periodontal diseases are amongst the most prevalent diseases. Most adults in their lifetime will have dental caries, which is tooth decay, and periodontal disease, which is infection of the gum. And if we look at the Sustainable Development Goals of promoting equity and closing the divide in, especially we have a very diverse country. South Africa is known as to be the most unequal country in the world. And this makes it imperative that oral health be seen as integral to health, and that populations that depend on our public health system have access to primary health care. Now, South Africa has adopted the primary health care approach to provide quality care to citizens, and this emanated from our reconstruction and of our healthcare system post 1994 with our new democratic health system or government. And this signaled a paradigm shift from a system that historically was vertical, in that health programs were offered as vertical programs that were medically dominated, to an integrated national health system. Now, as I've said, oral diseases are highly prevalent in South Africa, and there are significant consequences to health and well-being. We know that toothache, dental pain results in concerns around function, self-esteem, a loss of time from work and school. In addition, oral health and systemic health link is well known. We do know that with chronic illnesses, with infectious diseases, there are oral health impacts in terms of delayed healing or oral symptoms in the mouth that affects quality of life as well. So the very poor are affected in multiple ways, through poor oral health, through systemic health, and also the link between the two. Now, the literature suggests that oral health has not been fully integrated into the philosophy of primary health care, and that primary oral health care in our context is offered to a very limited extent within the primary health care system, and that dental extractions are still the primary treatment provided. And again, taking into account that we're looking at reducing the equity gap, this is a concern. So the primary healthcare approach created an opportunity to improve oral health of the population through access at the level of the home, the community, as well as the health facility, and this provides the context of this study. Just to get a bit of background to South Africa into our system, we've got the national health system. We have healthcare provided through the district system, and this shows, the map shows the Cape Metropole, and it shows the districts and also the sub-districts. So healthcare is provided at a district level, and I've just circled the area where this particular study is taking place. Often when we talk about the Cape Metropole, we talk about the tale of two cities, just showing that we have extreme poverty and we have extreme wealth, and we have in between of that. And so although this picture shows the, let me just show you. The bottom picture shows the ideal. Very often this is our reality, and this reality is very much linked to socioeconomic status and so forth, making it so important for primary health care to be servicing the entire population. So if one looks at the district health system, we have primary health care is driven by the district health system, and the core principles of primary health care is about prevention, promotion, and good quality essential care to meet the health needs of a defined population. And these health needs, of course, include oral health. And around 2010, globally, there was a view that primary health care should be re-engineered because although the principles remain the same, the way it was offered wasn't really creating access in the way it was intended to. So in our context, we added 3 streams to this primary health care engineering. And that was, and if you look at the diagram here, you've got your district management team that are responsible to manage a particular district. You have your facility, which is your primary health care clinics, as well as your community health services. And they are managed by facility managers, and they offer services which includes oral health. And then we've also got community outreach, and community outreach would include home-based care as well as broader community structures. And oral health we see to be integral to health. If we look at it a bit further, your district management team would look at governance at the level of the substructure, and then you've got managers at your facilities that will manage the facility, and this includes a dental clinic where there would be an oral hygienist, a dentist, and a dental assistant, and there would also be professionals from the different disciplines working in these facilities, but also offering community-based services. Then the ward-based outreach team, which is core to this whole revitalized or re-engineered approach. In this sense, you have community health workers taking a core role in that they are allocated to homes in a ward. We've got a municipal system where we have designated areas, and so we'd have one community health workers allocated to about 200 families, where they would reach out to those families. They would offer educational services, preventive services, some screening, and they would be a referral to the facility, and they are supervised by nurses and community health workers. So they form the core to linking communities to facilities. Just shortly, we do know in terms of oral health, we do know the risk factors, hygiene practices, reducing sugar, exposure to fluoride, and dental care. And although this might not be easy taking into account the economic situation, the fact that community health workers goes into the home, we could address these factors. To give you a sense of the specifics around the oral health status, a National Children's Health Survey was done between 1999 and 2002 involving children, and we've not had another subsequent national survey. These shows our provinces, and I just want to point you to the Western Cape province where this research is located. We find in children 4 to 5 years of age, 77% of them had tooth decay or dental caries, of which 72% was untreated. At the age of 6 years, it increased that 82% of them had dental caries, 75% was untreated. And again, if we look at the part of the population we're referring to, it is the underserved population. So oral diseases are increasing with age, but most of it is untreated, making prevention and promotion so critical. So the aim of this study was to explore the status, the current status, and also identify guidelines that would align primary oral health care better within the primary health care approach, and this is done within a substructure in the Cape Metropole in the Western Cape Province in South Africa. This was an exploratory study using a mixed method approach. The study site was a district or substructure, which is part of a district, and the study population included managers at the district level, as well as managers at health facilities, community outreach. Health workers were involved that provide health and oral health services, and these included oral health professionals, nurses, and community health workers. And data was collected by means of semi-structured interviews and focus group discussions for managers, as well as focus group discussions for nurses and oral health care professionals. We also did a scoping review to find out about programs where community health worker-driven interventions were successful. And we did a survey to inquire about community health workers in terms of their personal and work-related oral health knowledge, as these community health workers are often from the very communities where they work. So we wanted to know more about themselves. We also did a document analysis, and this is a mixed method study. The mixing methods allows for multiple sources, and this allows for triangulation of the data. The preliminary result shows that for the managers, managers at a district level indicated that the processes for primary health care and primary oral health care does support the integration of oral health into primary health care. And they basically said the structure of the plan, the re-engineered plan, was such that we could integrate, it should be integrated. However, managers at a facility level reported limited primary oral health care services being provided, limited integration of oral health into health. They also referred to the fact that there were health problems that appeared to have more significance, and that extractions was the most prominent treatment offered. Oral health professionals reported that they felt undervalued in the system, that oral health was not prioritized. There was a lack of resources to offer primary oral health treatment, lack of resources to offer conservative treatment such as fillings, that oral health programs were done on historical basis, not necessarily using evidence-based strategies. They also offered a range of community health services. The community health workers, who are seen as the cornerstone of the health system in that they provide community-based care and home-based care, for most part did not offer oral health services, although they felt it should be included. We found they did not have appropriate oral health knowledge, or practices within their work role or their personal lives in terms of basic oral care. In terms of policy documents, there was a disconnect between and within policy documents regarding primary care. I've just put this slide in to show the common risk factor approach, because even when oral health professionals worked with other professionals, they worked alongside, not really integrated, where, for example, one would expect that they would look at a risk factor such as diet or a risk factor such as tobacco and see how that risk factor affected many diseases and work together to address the risk factor. Rather, professionals would work alongside one another, but still independently. So in conclusion, if one looks at bridging gaps and understanding diversity, there's really a need to bridge gaps within the oral health team, between oral health and other professionals, also between managers at different levels, because oral health still appears to be offered as a vertical program within this revitalized system. Although primary oral health care is integrated at a program level, in other words, it's part of primary health care, it's not appropriately integrated into primary health care system. There's a need to access primary oral health care and better integrate it. So the preliminary results of this research shows that the state of primary oral health services will only increase the equity divide of the most vulnerable of the population. And the structure of the revitalized or re-engineered model allows for primary oral health to be integrated. However, such integration needs to be guided by principles that must be met at a minimum. That there are more references. Thank you very much for your attention.
Thank you so much. Your lecture is very amazing. Thank you, Dr. Natalie. I was very interested to hear your presentations, and I wonder we have one question for each speaker. So if there is any question, please post in question and answers, and we can answer your questions. And I have a question for Dr. Natalie. So I see your research, it occurred since 2000, right? You didn't update these results more recent since 2022, 23, or this project is still running now?
Sorry, are you asking me?
Yeah.
Oh, sorry. So no, no. The data of 2000 was the National Oral Health Survey that I referred to. So one of our concerns, the data that I collected was around 2021 and 2022. The concern is we still have using the data of the National Oral Health Survey for Children that was done between 1999 and 2002. And so it has not been updated that we know the current status of children. We do know that it's substantially worse than it was. But there's been no national survey. There's been small surveys, but no national survey.
Yeah. So if there's a question, please post in question and answer. Thank you so much for your presentation.
Thank you.
Actually, oral hygiene is very important, not as you mentioned, is a risk factor for many of the diseases. And infection in oral place invite many more dangers for rheumatic infection in heart, for example, especially in under age of 5 years. So very important.
That was one of the findings. We presented very preliminary basic findings, but what we did find that professionals who working in silos, and the dental professionals were saying that often the health professionals didn't know much about oral health. So they didn't know about the link. And of course, oral health professionals don't necessarily know much about health. So that in terms of basic training, there is a need for us to know more about common risks, because people do seem to run programs independently. One will teach about hand washing and the other will teach about mouth cleaning, but they do not look at it together in terms of basic hygiene.
Yeah. Yes, this is your big challenge for your research. Yes. So every speaker will please mention your challenge for your research. Dr. Christine, you are still here. Dr. Laura, please, what is the challenges face you for your research as a scientist and female?
First, a collaboration is very a big challenge. Collaboration is another ministry, health ministry. I am in a ministry of research, and a collaboration with a colleague in the Ministry of Health is very difficult to write one project to collaboration of conference of anything is very difficult for us.
Yeah, yes, thank you so much. Dr. Christian, you are here.
I can add, please?
Yes, please.
Yes, financement and language barrier language is very difficult for us to obtain financement, and many organizations insist to write in English, but it's very not easy for us to write project in English and to submit and to obtain financement, because competition is very hard.
Yeah,
it's very hard, and is a big challenge for us to speak English because it's not a maternal language. And to write, I write in English, but my language, my pronunciation is not good. But I write many articles in English, but speak is very not easy. And participate in a conference, in a workshop in English is very not easy. But is very now today is my challenge. When I see us to speak English very easy, I say today I begin to improve my English.
Excellent.
Because I lack many opportunities.
Yeah.
Yeah.
Yeah. English language is an universal language. Yes. By the way, all of us is our native language is not English, so it's okay, no problem. Thank you.
Dr. Mahmoud, I was interested in you saying in your presentation that you're trying to get people not to be so dependent on the hospital, that there would be a smartwatch or something that would monitor them. Do you see this happening? Is it in place already in some areas, or is it? Because that is at least something we would need, in terms of access, because we cannot have everybody. We just don't have space for people to come to our primary health care. So do you see possibilities in especially our less developed countries?
I mentioned that's my dream. Is my dream that all patient has, but actually now I have a project and I am the principal investigator of this project about breast cancer patient, and we will apply a smart application in smartphones to connect patient with hospital and to connect patient with us, to monitoring the process of treatment, management, diagnosis for the patient. I know that will make will face many challenges like internet stability, like smartphone. At first, not all people or all females have smartphones, but at least one in the family will have smartphone. So I know it's in the beginning as artificial intelligence. It's in the beginning environment especially in developing country, least developing country. But if we can introduce something like this, it will be good in primary health care, for example. So I think we have no more questions, and we can close our session. Thank you so much, Dr. Natalie, Dr. Laura, and Christine. Thank you so much, Irina. I am so honored and very pleased to be with you today. I hope you enjoyed the session, and I hope all attendees like our presentations and stay with us more attention. Thank you so much, and a floor for you if you need to say any point. Yes.
Oh, thank you so much. Thank you so much, all the speakers, and I really thank you, particularly Dr. Linguisti, to agree on speaking in English, and I truly apologize that we needed to push and to close because it's really a pity, but we have a limited amount of time. But I hope that we will engage soon again. And Dr. Vala Mahmoud, what is your biggest challenge? And then it's our last question, then we close the session.
My biggest challenge in my research work.
No, what you see, what is the biggest challenge? Sorry, for now and for the future related to your research, of course. What do you think that is the biggest
funding opportunity? It's a fund. Yes, I need the more fund opportunity because we have many topics and many research points, but need a huge fund to make it the reality on the real world. As I mentioned before, the idea of application, smartphone, connecting patient and hospital need money because artificial intelligence is not cheap. It's a little bit expensive. Making algorithm, making the module or models, artificial intelligence models, the engineering, all this need money. So my biggest challenge is funding opportunities.
Thank you so much. And thank you, Miss Natalia Gordon. It was really a pleasure having you. And thank you, Dr. Christian Olea and Dr. Linguisi. And thank you so much for this great session, and see you soon again. Thank you. Bye.
Thank you.
Thank you.
Bye. Bye. Bye.
Thank you.
Have a nice day. Bye. Bye.